My jazz makes me special. My doctor prescribed Tagrisso.
Ask your doctor if Tagrisso is right for you.
All right, I think we're ready to get started. Well, hello and welcome to this special edition of the Outcomes for Me Ask the Expert webinar series. Today, we're privileged to connect you with a leading expert in lung cancer who's here to address your questions. Thank you for being part of this important conversation. For those of you who may be joining for the first time, my name is Neil Margolis. I lead the development of clinical content and treatment algorithms as Outcomes for Me. Our platform, driven by the latest AI technology, is dedicated to empowering cancer patients by providing them with personalized, evidence-based treatment options and vital information. Working alongside a dynamic team, I'm committed to democratizing healthcare, ensuring that every patient has access to tailored information about their diagnosis, treatment options, testing recommendations, and the latest in clinical trials, news, and education. Outcomes for Me exists because we believe in equipping patients with the tools they need to actively engage in their care with a full understanding of their options and the newest research in cancer treatment. For today's webinar, we're honored to have with us Dr. Jessica Lin to discuss the latest advancements in lung cancer care, particularly as it relates to biomarker testing and related insights. Dr. Lin is a medical oncologist in the thoracic oncology program at the Henri and Belinda Termeer, I hope I got that right, Center for Targeted Therapies at the Mass General Cancer Center, and Associate Professor of Medicine at Harvard Medical School. The primary focus of Dr. Lin's research is to develop novel therapeutic and biomarker strategies for patients with advanced lung cancers. As a clinical investigator, Dr. Lin is deeply involved in the design and conduct of clinical trials, evaluating novel targeted therapies as well as combination regimens. Her translational research efforts are dedicated to the study of resistance mechanisms and exceptional responses to targeted therapies in molecular-defined subsets of lung cancer, such as those harboring ALK, ROS1, and RET gene fusions. The ultimate goal of our research is to improve outcomes for patients living with lung cancer. Welcome, Dr. Lin. Could you please start us off by introducing yourself and sharing anything that I might have missed with our community?
Oh, thank you, Neil, and thank you for this kind introduction. You really didn't miss anything. As you heard, I'm a thoracic medical oncologist at the Massachusetts General Hospital in Boston, and I would just add that I'm really happy to be here today, and I want to thank you, Neil, and the group for inviting me.
All right, thanks, and great to hear. So I always like to get started by asking our doctors, are there any myths about lung cancer or about molecular biomarkers in lung cancer that you could address?
Yes, that's an excellent question. I say that one myth that I always like to start off with is that lung cancer can affect anyone with lungs. There is today a lot of misconception about how lung cancers only affect patients who have heavily smoked cigarettes before, and this is a stigma that many patients and families affected by lung cancer have to live with, and it is simply not true. In fact, many of the patients that I treat in my clinic have never touched a cigarette in their entire lives, and so we've learned over the years that there are certain subtypes of lung cancer that are actually more common in patients that have never smoked before. This is a myth that is important to really get rid of in the coming years, hopefully. Another myth that I would turn people's attention to is something that I hear a lot from patients, actually, which is a concern and a worry that somehow if you're seeking a second opinion or consultation with an expert in the field, that your primary oncology team or your doctor may take offense or view it in a unfavorable way. And that is simply not true. I think in the oncology community, we all always encourage second opinions. We're always actually communicating with each other and asking for other oncologists' thoughts and input in your care. And so you should definitely feel empowered to ask for second opinions and get consultations, particularly when you're initially diagnosed with lung cancer, but also during the course of treatment, if you're needing to change therapy or just at a challenging time point in your cancer therapy, it's always good to consider.
All right, thank you. That is great advice, and we appreciate it. So, can you help our audience understand what biomarker testing is, how it helps identify specific mutations for the cancer, and alterations that impact cancer growth?
Sure, this is a really great way to start the discussion about lung cancer, because if we take a step back, um, it's really critical to understand that lung cancer is not one disease. It's not every lung cancer is the same. In fact, lung cancer is very much a heterogeneous illness that's comprised of many different subtypes, which all have distinct characteristics and distinct biology. And so the term biomarker testing, it's referring to testing a patient's specific lung cancer for either the presence or absence of alterations in different genes, or for level of expression of certain proteins that we know are important in understanding the cancer biology and also in helping determine the optimal treatment for the patient. And biomarker testing has become an essential part in the initial diagnosis of lung cancer and in treatment decision making.
All right. And one of the common questions we hear at Outcomes for Me is, how does biomarker testing or genomic testing differ from genetic testing?
It is indeed a very common question that we get asked as well in the lung cancer field. And that's because the two terms are often used interchangeably by patients and families and also by oncologists. But in fact, they're not, they're distinct terms, although they are related. Biomarker testing is more inclusive. It refers to not just gene testing on the cancer, but also other testing like looking at protein level expression. As an example, we perform testing looking at the level of a protein called PD-L1. This is a really important protein in lung cancer diagnosis and management because it can tell us how likely it is that a patient's lung cancer will respond to a form of medication called immunotherapy. And PD-L1 expression testing is not part of gene testing. Gene testing is looking for mutations or structure changes across cancer-related genes. So a truly interchangeable term for biomarker testing in lung cancer may be more molecular testing, quote unquote, rather than genetic testing. Another distinction that I want to point out is that sometimes people use the term genetic testing to refer more to testing for hereditary gene changes or mutations, meaning those changes in genes that are passed down from your parents to yourself or perhaps to your children or any kind of blood-related relatives. That is a very specific kind of blood genetic testing. More broadly, when we say genetic testing, it can be done to look for not just hereditary mutations using blood samples, but it can also be done to look for non-hereditary but cancer-specific mutations, and it can be done using either blood sample or using tumor sample that's taken through a needle biopsy, for example.
Okay. So what does personalized treatment mean when it comes to non-small cell lung cancer?
Personalized treatment is increasingly how lung cancer is treated. We often say that lung cancer is an excellent example of how precision medicine is done in cancer care, because what we're seeing is that a lot of the lessons and insights we've gained through precision medicine in lung cancer are being used to make advances in other types of cancer as well. So what personalized treatment means is that we match how we treat patients with non-small cell lung cancer to what we know about the specific biology of the lung cancer and what we know based on biomarker testing. So we're matching the treatment to the biomarker that is identified on the patient's cancer assessment. One common example that we use is for patients who have lung cancers that have a mutation in a gene called EGFR. I use that example because it is the earliest identified mutation in lung cancer for which we use that kind of matched biomarker-directed therapy. For those patients, we would not start out with immunotherapy and chemotherapy. Rather, we would recommend starting out with a pill that blocks the function of that EGFR gene. It's called an EGFR inhibitor, or some people use the term EGFR TKI, short for tyrosine kinase inhibitor. As another example, for patients who have lung cancers that have a structural change in a gene called ALK or ALK, we'll start out with the matched therapy, which is an ALK blocker or ALK inhibitor pill. And this list continues on and on. And in fact, the panel of biomarkers that we're testing for in patients diagnosed with lung cancer just keeps increasing over time. And so the treatments are becoming more and more granular and more personalized, which is a great thing for patients. It means that we have increasingly precise, highly effective therapies that we can reach for that are specific to the patient's own lung cancer.
Okay, yes, and I know from my own experience in the oncology field that non-small cell lung cancer and the number of biomarkers is increased. I think when I started, it was EGFR and ALK had just come onto the onto the stage, so it's quite a few now.
That's right.
I think probably a question you get all the time is, when does a doctor do biomarker testing, especially in an early stage lung cancer, and what happens if your doctor doesn't bring up biomarker testing at an early stage? Should you be asking about it?
Yes, for patients with lung cancer, when you're initially given the diagnosis of lung cancer, that is a critical time point for doing biomarker testing. For many years already, national guidelines, including the NCCN guidelines, which is what the oncologists refer to for kind of standard of care therapy and diagnosis a routine, these guidelines have recommended biomarker testing for every single patient newly diagnosed with advanced stage or metastatic non-small cell lung cancer. So that's kind of old news. And then more recently, biomarker testing is also recommended and part of routine care for patients diagnosed with earlier stage non-metastatic lung cancer, meaning that includes patients with stage 1 to stage 3 lung cancer. And the reason that these guidelines have been expanded for biomarker testing is that we've learned that these results do impact post-operative care or perioperative care, and also for patients that received chemoradiation for stage 3 lung cancer. But there have been studies done in the recent years looking at, so biomarker testing is recommended for patients with lung cancer. How successful are we in actually doing the biomarker testing? And the results and the statistics have been really sobering. There are many patients to date, even those patients with metastatic lung cancer, who don't get the right panel of biomarker testing performed. In some studies, it'll say the rate is as low as 50% or lower. 50% or lower frequency of patients getting the testing that they need in terms of biomarkers. And so all that is to really emphasize that it's important to be aware of the recommendation for biomarker testing in lung cancer and to make sure it is done. And absolutely, I would say patients should bring it up and ask about biomarker testing with their doctors. You should feel empowered to do this. There may be a reason, one reason or another, that they don't talk about it or that it's not done. But if you don't ask about it, you will not understand why, right? So if there was a specific reason that a particular biomarker testing was not done or that you haven't been informed about it, you want to understand why. So I would absolutely encourage that you talk to your doctors about it.
Yeah, that is a shocking statistic that you just gave us. And you mentioned there may be some reasons why. What types of reasons would would the physician not recommend or not bring up biomarker testing?
I think the guidelines are evolving so fast in lung cancer, both in terms of new therapies that are available and also in terms of the panel of biomarkers to test, that sometimes there is a delay in the adoption of the new guidelines, especially out in the community. For example, as you said, Neil, for many years we've known that EGFR and ALK are actionable gene alterations in lung cancer where we can match to targeted therapies. And so I would say EGFR and ALK are more commonly tested for than some of the newer targets that have been identified, like MET exon 14 skipping or HER2 mutations or KRAS mutations even. And so the rate of testing for a specific biomarker is variable depending on how much is known about the biomarker. But a lot of it also has to do with the practical challenges of biomarker testing. Just as one example, not every patient has a tumor that is easily accessible and safe for biopsy. So some patients may have lots of small lung nodules where it's not at a size that's big enough for biopsy, or some patients may present with a lot of cancer burden, but they may all be concentrated in the brain, for example, and brain biopsy is super invasive and it's not always doable. Other times, a biopsy is successfully performed and we have the diagnosis of lung cancer, but there is just not enough tissue left over to do all the biomarker testing, like gene sequencing, for example. And so you run out of tissue that's necessary to do the biomarker testing. And to arrange a repeat biopsy and wait for the results to come back can often take weeks, and that just may not be affordable, and that may lead to hesitation in making sure all the biomarker testing is done. These are some of the more common reasons that I come across when I'm seeing second opinions of patients and not all biomarker testing have been done. These are the reasons that I'm seeing most commonly.
I see. That makes sense. Are there liquid biopsies available that can help, or are there any in development?
This is a highly relevant question these days. So yes, absolutely. Liquid biopsy is becoming increasingly used in lung cancer and throughout other cancer types also. Liquid biopsy refers to using a liquid sample, most commonly blood sample, to do the biomarker testing. And so in patients with lung cancer, we often use blood biopsies to look for particular mutations or gene changes. And often liquid biopsies can be quite helpful. So for example, in patients where tumor biopsy is not easily doable or safe, blood biopsies, I have had those patients for whom liquid biopsies ended up giving me the information I need. That said, I think of liquid biopsy as very much complementary to tumor biopsy. And so liquid biopsies are incredibly helpful when they come back revealing a gene driver, but sometimes they come back blank, as in they don't come back showing any gene changes. And there are two possible scenarios to explain that, right? One, that there truly is no targetable gene alteration in the patient's lung cancer. But the second possibility is that there just wasn't enough cancer DNA shed into the bloodstream. And so it was what we call a non-diagnostic test, meaning that when the liquid biopsy picks up a gene alteration, that tends to be highly reliable. But if it doesn't pick up anything, then we're back to square one, and we have to then really consider doing a tumor biopsy to make sure that a truly diagnostic biomarker testing was indeed performed.
Okay. And do many patients just simply have no identifiable mutation, driver mutation?
There is a fair subset of patients for whom there's no targetable driver. That said, if you look at patients, for example, who've had no smoking history or who've minimally smoked before, a significant proportion of those patients, well over half of those patients, will have a targetable gene alteration. And so my practice is to say, if you've had a liquid biopsy and it came back blank, to definitely try and do a repeat tumor biopsy if that's safe.
Okay. So we had some questions about immunotherapy, about targeted therapy, and you mentioned PD-L1, the protein previously. Do you want to talk a little bit about PD-L1, what it is, and how we attack it?
Yes, a PD-L1 test, it's measuring what percentage of your lung cancer's tumor cells express the protein called PD-L1. This is a marker that research has shown can be associated with the degree of benefit that patients can derive from immunotherapy. Immunotherapy is one of the three major buckets of medications that we reach for in lung cancer. So one bucket is chemotherapy. That's the oldest form of treatment for lung cancer. Second bucket is targeted therapy. This is where medications are matched to specific gene abnormalities in the tumor, what we're referring to many times with precision medicine. And then the third bucket is immunotherapy. And immunotherapy is trying to unleash your body's immune response against cancer. And so it's trying to boost the body's ability to identify cancer cells as something that doesn't belong and to destroy them. And immunotherapy is often administered intravenously like chemotherapy, but the two classes of medications have really distinct side effect profiles. And so with PD-L1, what we know is that when lung cancers express a high level of PD-L1, and by that, the cutoff is 50% of tumor cells expressing PD-L1, or more than 50% of tumor cells expressing PD-L1. For those lung cancers, there's a significantly higher likelihood of response to immune checkpoint inhibitors. Examples being drugs like pembrolizumab, nivolumab, atezolizumab, and so on. And so for you, let's say if your biomarker testing comes back showing that there's no targetable gene alteration, but there's a high level of PD-L1, then the standard first treatment that your doctor will discuss may be immunotherapy by itself because of that high level of PD-L1, or sometimes your doctor will still discuss adding chemotherapy to immunotherapy to try and get at a faster and a greater magnitude of response. On the other hand, let's say that a patient's lung cancer has low level of PD-L1 expression or no PD-L1 expression. Then our confidence in using immune checkpoint inhibitors by themselves without chemotherapy becomes lower because the likelihood of benefit is lower. And so in those cases, our recommendation for initial treatment will almost always be adding on chemotherapy to immunotherapy as long as we think your body can tolerate the side effects of chemotherapy.
Okay. So we had a couple of questions that seem quite practical, which about biomarker testing, and they're related. One is, how long does it take to get biomarker testing results, and should you wait for your treatment to start until you get the results of biomarker testing?
Yes, very practical and important question that I get asked often by oncologists as well. And I'm glad that this question is asked because the reality is that often there is a wait time for all the biomarker testing results to come in. And results may also not always come in at the same time. They roll in. So PD-L1 result may come in first before the next generation sequencing results come in to look at gene alterations. But we've learned that if a patient starts on immunotherapy, let's say the PD-L1 result comes back high and NGS results have not yet come back, but based on the high level PD-L1 result, a patient starts on immunotherapy. then let's say the NGS testing comes back, shows a EGFR mutation. In that case, you would want to switch to EGFR targeted therapy or EGFR inhibitor. But what we've learned is that when there's prior immunotherapy exposure and then a switch to targeted therapy happens, there can be increased risk for certain toxicities. For example, with EGFR inhibitor osimertinib, if there's prior immunotherapy exposure, there can be increased risk of pneumonitis, meaning inflammation in the lungs that can lead to significant shortness of breath or cough. With other targeted therapies, we've seen that after prior immunotherapy exposure, there can be significant liver toxicity or really diffuse severe rash to the point of requiring hospitalization and sometimes intensive care unit stay as well. Because of this, our recommendation is to make sure that the gene testing result, the NGS result, is available to know whether you're a candidate for targeted therapy or not before immunotherapy is initiated, even if that PD-L1 result has already come in. So what does that mean if a patient is suffering from symptoms of lung cancer like pain or shortness of breath and really just needs to start on treatment right away and biomarker testing results are not yet available? It's really hard to just sit and wait in those circumstances, right? And it's not the right thing to do either. So in those circumstances, what we commonly do is to go ahead and treat the patient with a dose of chemotherapy without immunotherapy, because then what we do is we minimize that risk of added toxicity, but we're allowing at least one cycle of chemotherapy to go in and try and temper the cancer burden. Often, the first chemotherapy we reach for patients with non-small cell lung cancer is given every 3 weeks. So before the next dose is due, typically we get all the biomarker testing results back so that after that first dose, before the second dose of chemotherapy is due, we're then able to say, okay, now all the results are available. Are we going to pivot to targeted therapy? Are we going to pivot to immunotherapy and so on and so forth?
Okay. And in that case, if you did get back a result that the patient had an EGFR mutation, do you switch or is that additive with chemotherapy or how does that work?
Gosh, that would have been, my answer would have been very quick if you asked me this question a year ago. Today, it's quite a sophisticated question. So a year ago, I would have said, absolutely. So after the dose of chemotherapy, if the gene testing comes back showing an EGFR mutation, switch to the EGFR inhibitor. And right now, the standard first EGFR pill to go for is osimertinib. The reason it's a very nuanced question today is because just over the past year, there have been a couple large clinical trials that have been reported out where they looked at the first-line treatment option for patients with advanced EGFR mutated lung cancer. And one trial, for example, looked at chemotherapy together with osimertinib compared against osimertinib by itself. And there was a benefit in progression-free survival. It was a positive trial. And so now chemotherapy plus osimertinib is also considered a standard initial treatment option for this patient population. So now that discussion is more complicated. If you have metastatic EGFR mutated lung cancer, your doctor will probably discuss both options, and then they'll tell you, okay, because of these reasons, let's go ahead with osimertinib alone, or because of these reasons, let's go ahead and do osimertinib together with chemotherapy. So it's a lengthy discussion, but regardless, if the biomarker testing shows an EGFR mutation, then yes, you will be shifted towards EGFR-directed treatment algorithm.
Okay, well, I'm glad to see all this progress is being made, and I'm sure will continue to be made. In looking at biomarker testing, do you often see multiple driver mutations, or is it typically just a single driver mutation that exists?
Another fantastic question. Almost always, but not 100% of the time, there is a single oncogene driver for lung cancer, meaning that if a patient has biomarker testing done and the NGS report shows an EGFR mutation, probably there isn't going to be also an ALK rearrangement or a KRAS mutation. If a patient's NGS report comes back showing a HER2 mutation, HER2 mutation, there probably isn't also going to be a classical EGFR mutation. There have been very rare case reports where more than one oncogene driver has been identified in a patient's lung cancer at initial diagnosis. Now, the timing of the biomarker testing matters. Increasingly, for patients who do have an actionable target, like an EGFR mutation or an ALK rearrangement identified in their lung cancer, and they start out with targeted therapy, and appropriately so, when their cancer relapses and starts growing again, some oncologists repeat the biopsy and redo the gene testing. At that time point, often we do find mutations in more than one oncogene driver, but that is a very distinct scenario from the initial diagnosis of lung cancer for the purposes of the treatment decision-making at that time point.
Okay, well, that makes sense. So getting into some specific drivers of cancer in non-small cell lung, it sounds like EGFR is a pretty common mutation. Could you tell us more about the EGFR mutations that exist and what treatment options are available for those? You've mentioned osimertinib, of course, but I know there's a few.
I could spend multiple hours talking about this question because there are so many layers to the discussion about EGFR mutation. So first, not all EGFR mutations are the same. There are many subtypes of EGFR mutations with different treatment paradigms in lung cancer. Often when we use the term EGFR mutated lung cancer, we are referring to lung cancers with classical EGFR mutations. These are the most common EGFR mutations that we see in lung cancer. Specifically, there are two classical EGFR mutations. One is EGFR exon 19 deletion, and two is EGFR L858R mutation. These are the ones where the pill that we talked about, the EGFR inhibitor, osimertinib, and others, have been used for years, showing really great effectiveness. But there are other EGFR mutations too, where pills like osimertinib don't work as well, and where we pull in different EGFR targeted therapies or different treatment strategies. So that's an important point to make. So if you're told that your lung cancer has an EGFR mutation, it's important to learn, well, what kind of EGFR mutation is it? Because that affects what treatment is the optimal one to go to as a next step. The second point to make about EGFR mutations is that there are a number of different EGFR targeted strategies that are being used in the clinic now, where we often talk about drug like osimertinib, first treatment option when you're initially diagnosed, but to know that there are later treatment options that are also directed towards the EGFR mutated lung cancer that your oncologist will be able to turn to if the cancer were to grow on a pill like osimertinib. Okay, so having a biomarker identified in lung cancer is not only important for that first treatment decision, but it also affects subsequent treatments that represent options for you, and also affects the optimal clinical trials to consider down the line as well. The final third point I will make is that EGFR mutated lung cancer is the first subtype of lung cancer where we have moved targeted therapy from being used only in patients with advanced stage lung cancer to now being used for earlier stage as well. And so EGFR mutated lung cancer, let's say a patient has stage 1 or stage 2 EGFR mutated lung cancer that was resected surgically, okay, then the patient received postoperative chemotherapy. A couple years ago, that may have been the end of it, but now we do recommend following with postoperative EGFR inhibitor targeted therapy because we have a clinical trial data that show that doing so can improve the patient's disease-free survival and overall survival. And so this is one subtype of lung cancer where definitely targeted therapy is used in earlier stage lung cancer.
Great. All right. So along with EGFR mutations, of course, there's a number of other mutations. What are some of the more common ones that you see in your clinic?
So EGFR mutations, the classical EGFR mutations are found in anywhere from 10 to 15% of patients with non-small cell lung cancer. Another relatively more common one is ALK rearrangement. So ALK gene rearrangement is seen in anywhere from 3 to 5% of patients with lung cancer. And if this is the case for you, then doctors may discuss ALK inhibitors like lorlatinib or alectinib with you. And for patients that have surgically resected ALK rearranged lung cancer also, we use ALK targeted therapy postoperatively. Alectinib is considered standard of care postoperative therapy if you have that subtype of lung cancer. Other ones that we see in patients, there are other gene rearrangements like ROS1, ROS1 gene rearrangement, or RET, RET gene rearrangement. These are both seen in anywhere from 1 to 2% of patients with lung cancer. And then there are other mutations in genes. So we mentioned quickly the MET exon 14 skipping mutation. That one affects the MET gene, and it's seen in 2 to 4% of patients who have lung cancer. We have HER2 gene mutations that are seen in 2 to 3% of patients with lung cancer. And I have to mention mutations in KRAS. And I have to mention it because KRAS mutations are actually one of the mutations that we knew about the earliest. We knew about KRAS mutations for a very long time, but we used to refer to KRAS mutations as being undruggable because there were so many challenges with developing treatments that are targeted to KRAS mutations. It was just such a difficult feat. But over the recent years, there have been targeted therapies that have been successfully developed for a specific subtype of KRAS mutation called G12C. And there are other subtypes of KRAS mutations for which targeted therapies are now being rapidly developed as well. So KRAS mutations are actually very common in lung cancer. The G12C KRAS mutations for which we have approved targeted therapies are seen in about 13% of patients with lung cancer. And so that is another important one to watch out for.
Okay. And we did get a couple of questions asking about the MET exon 14 skipping mutation. Could you tell us a little bit about that and treatment options for that mutation?
MET exon 14 skipping mutations are one of the gene alterations that are detected using next generation sequencing, where you have broad panel gene testing. And these mutations result in a lot of the MET protein being expressed in the lung cancer cells, and these lead to increased lung cancer cell survival and growth. We have 2 FDA-approved MET inhibitors, MET-targeted therapies, that can be accessed for treatment if your lung cancer has a MET exon 14 skipping mutation. These MET-targeted therapies are called capmatinib is one of them, and tepotinib is the other one. And both of these in separate clinical trials showed really robust activity in this subset of lung cancer.
Okay. How about up and coming, I guess, biomarkers that maybe people are starting to see or test for or found in clinical trials? anything that we should be aware of?
So one important one that I will repeat is the KRAS mutation. And so we used to not really pay that much attention to KRAS mutations because we didn't have targeted therapies available. But now we have one KRAS mutation for which there are FDA-approved targeted therapies and several others for which there are promising clinical trial agents. And so KRAS mutation is definitely an up and coming one for lung cancer and other cancer types too. Another one for which there are clinical trials is a gene rearrangement affecting the NRG1 gene, NRG1. So that is another one for which we have investigational agents that have shown some promising activity where it could be worth considering after standard first treatments. There are other ones like, for example, MET amplification. So we talked earlier about MET exon 14 skipping mutation, right? There's another way in which the MET pathway can be activated, and that is through amplification or multiple copies of the MET gene. There, again, targeted therapy could be worth considering. So that is also important to watch out for in the NGS report.
Okay. And I know you're doing a lot of research in this area. Any biomarker-related clinical trials for patients with metastatic non-small cell lung cancer that we should be looking for?
There are so many.
Right.
So for each biomarker that we just reviewed during this session, during this webinar, there's a whole array of clinical trials. For EGFR mutation, there will be EGFR mutation-specific clinical trials. For ALK, there are ALK-specific clinical trials. Of course, there are a spectrum of trials that are agnostic to the gene biomarker as well. But for every subset of lung cancer, I would say there are more than 10 different clinical trials. And so this is another reason why biomarker testing is critical, because it not only affects the recommendation for the standard FDA-approved therapies, but also affects access to promising clinical trials down the line. And another reason that second opinions and consultations are really important, because every center will have a slightly different or dramatically different clinical trial portfolio. So not all centers will have the same range of clinical trials open. And so this is why consultations at other academic centers can be incredibly helpful.
Yeah, okay. Well, it's an exciting time in cancer in general and non-small cell lung cancer as well. For a patient with earlier cancer who's tested as a PD-L1 less than 1%, is there ever any reason to move towards immunotherapy or other tests that you would do there?
That's a great question. So if the PD-L1 level is less than 1%, again, the first thing I would do is ask, has other biomarker testing been performed? For example, you mentioned, I think, early stage, right, Neil?
Yes.
So for surgically resected lung cancer, now there are FDA-approved targeted therapies for lung cancers if there's an EGFR mutation or an ALK rearrangement. So make sure that that testing was done, because often it will be missed. But increasingly, there's an effort to look at other genes as well, because there are clinical trials that are looking at surgically resected lung cancers with other gene drivers also, for example, RET rearrangement. And so some centers, there's an expanding panel of biomarker testing that's being done for resected lung cancers.
Okay. We have a question again, another undoubtedly common question that you hear about palliative care and hospice and your recommendations and really just the general, concern and fear, honestly, of patients when it comes to pursuing palliative care or hospice in a metastatic lung cancer situation.
Thank you very much for asking this question. This is actually one of the myths that I should have addressed at the very beginning of the webinar. Palliative care and hospice, the first important point I will make is that these are distinct terms and concepts. Palliative care refers to a type of medical care that is provided aimed at improving the patient's quality of life by ameliorating symptoms that may be related to the cancer itself or related to cancer treatment. And it's aimed at reducing the suffering of patients overall. In lung cancer, we have data that showed that early engagement of palliative care, even at initial diagnosis of advanced lung cancer, for example, can improve patient survival. Not only the quality of life, which is super important, but also survival. And so I personally recommend palliative care support as early as possible. Now, sometimes patients ask me, why are you referring me to palliative care? Isn't that for when cancer becomes much more advanced and there's no treatment options? And that is not true. Palliative care involvement is even more effective if they're following you longitudinally, even initially in the course when the treatment's being effective and successful. As early as possible is what I recommend. Hospice is medical care for patients where cancer can no longer be effectively controlled using treatment modalities that we have available, whether it's with medications or radiation. And if all viable treatment options have been tried, but patients are too sick or weak, then we may layer on hospice support to help manage symptoms and minimize suffering. And this can also be provided, not just at the facility, it can be provided at home as well, if that is what the patient wants. If the patient wants to maximize time at home, then absolutely hospice support can be set up to be delivered. I think of it as like a maximal layer of support that can be provided beyond visiting nurse or beyond home-based palliative care. And so palliative care and hospice are very different. Palliative care, important to engage early on, even when you're initially first diagnosed with lung cancer. And then hospice is a service that we engage later on, but different layers of support.
Okay, well, that's very valuable, I think, for a lot of patients, and it's great to hear doctors talking about palliative care early on. And I vaguely remember 13, 14 years ago when that paper came out, and it was hopefully practice changing.
Yes, absolutely.
Right. Are there any other questions that maybe you'd like to entertain? I've gone through our community questions and my own questions. I just want to make sure that if there's something you want to address, it would be a great time.
I think we covered a lot of it. Yeah.
Yeah, no, I think this has been a great discussion. Very helpful. Thank you, Dr. Lin. And to the community, if you have any follow-up questions or thoughts, please email us at questions@outcomesforme.com or enter it into the Ask Now box in the Outcomes for Me app, and we'll be in touch. We'll make a recording of this video available in our app if you want to revisit it or share it with others. To make sure you don't miss any future updates, download the Outcomes for Me app. If you haven't already, enable push notifications. Thank you so much, Dr. Lin, and thank you to the community for taking the time to join us today. Have a great day.